In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion about common types of neuropathic pain. Now, read the question.
Hello, doctor. What are the common types of neuropathic pain?
Well, while there are countless types of neuropathic pain, some of the prominent types include carpal tunnel syndrome. Is caused by nerve compression in the wrists and causes pain in the wrist, thumb and fingers. Central pain syndrome can occur after nervous system damage, such as a stroke. Degenerative disc disease, one may feel neuropathic back pain if it causes damage to the nerves entering or exiting the spine. Diabetic neuropathy causes stabbing pain in the hands and feet of some diabetic patients. Phantom limb pain can occur in some patients after a limb is amputated. Postherpetic neuralgia is brought on by an outbreak of shingles and persists after the condition has cleared. Pudendal neuralgia is a type of pelvic pain caused by compression of the pudendal nerve. Sciatica is caused by compression or irritation of the sciatic nerve and often results in shooting pain that radiates down the back of the leg. Trigeminal neuralgia is characterized by shooting neck and facial pain. Question 26. You hear a discussion bronchodilators used to treat chronic obstructive pulmonary disease. Now read the question.
Hello, doctor. What are the different types of bronchodilators used to treat chronic obstructive pulmonary disease?
Patients with chronic obstructive pulmonary disease are often prescribed a bronchodilator, a type of medication for relaxing the air passages to help breathe better. Typically, the medications are inhaled through the mouth using a metered dose inhaler, but also come in liquid, pill, injectable, or suppository formulations. The 3 classes of bronchodilators commonly used to treat chronic obstructive pulmonary disease are beta-adrenergic, beta-agonists, anticholinergics, methylxanthines. Beta-adrenergic agonists are a type of medication that binds to specific receptors in the lung called beta-adrenoceptors. By doing so, they block the trigger to bronchial spasms and allow airway passages to open. Beta-agonists can either be short-acting or long-acting, which are delivered either orally or through a metered dose inhaler. Generally, the inhaled method is preferred as it alleviates symptoms faster. Anticholinergic blocks the neurotransmitter acetylcholine in the central and the peripheral nervous system to its receptor in nerve cells and inhibit parasympathetic nerve impulses. Methylxanthines affect not only the airways but stimulate heart rate, force of contraction, and cardiac arrhythmias at high concentrations. Question 27. You hear a discussion about pancreatic neuroendocrine tumors. Now read the question.
Doctor, what are the various types of pancreatic neuroendocrine tumors?
There are different kinds of functional pancreatic neuroendocrine tumors. Gastrinoma usually forms in the head of the pancreas and sometimes forms in the small intestine. Most gastrinomas are malignant. Insulinoma forms in the head, body, or tail of the pancreas. Insulinomas are usually benign. Glucogenoma forms in the tail of the pancreas. Most glucogenomas are malignant. VIPomas, which make vasoactive intestinal peptide. Somatostatinomas, which make somatostatin. Question 28. You hear a discussion about melasma and different types of melasma. Now read the question.
Hello, doctor. What is melasma and what are the types of melasma?
Well, melasma is a common patchy brown, tan or blue-grey facial skin discoloration, normally seen in women during their reproductive period. It typically appears on the upper lips, upper cheeks, forehead and chin of women of 20 to 50 years of age. There are 4 types of pigmentation patterns are diagnosed in melasma: epidermal, dermal, mixed, and an unnamed type found in dark-complexioned individuals. The epidermal type is characterized by the presence of excess melanin in the superficial layers of skin. Dermal melasma is defined by the presence of melanophages throughout the dermis. The mixed type includes both the dermal and epidermal type. In the 4th type, excess melanocytes are present in the skin of dark-skinned individuals. Question 29. You hear a discussion about possible causes of arthritis. Now read the question.
Hello, doctor. Can you tell me what are the possible causes of arthritis?
Osteoarthritis is associated with cartilage damage. Genetic conditions are thought to play a role in osteoarthritis. Age alone is no longer seen as the cause of osteoarthritis. Rheumatoid arthritis is an autoimmune disease that develops as the immune system malfunctions and attacks the body's own tissues. Gout develops when excessive uric acid accumulates in the body and crystals are deposited in the joints. Reactive arthritis causes joints to become inflamed as a result of an infection that triggers the immune system. Usually, this condition resolves. Question 30. You hear a monologue of a physician on granulomas. Now, read the question. Granulomas are tissue nodules of immune cells that occur in diseases such as sarcoidosis and tuberculosis that can damage many organs. It is the chronic activation of the metabolic sensor mammalian target of rapamycin that is responsible for the granuloma's formation. In sarcoidosis, this mechanism leads to a course that is chronic and difficult to treat. Since mammalian target of rapamycin inhibitors belong to a group of drugs already licensed for clinical use, these findings offer new and quickly testable treatment options.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear a healthcare practitioner talking about aspects of their work. For questions 31 to 42, choose answer A, B or C, which you think best fits according to what you hear. Extract 1, questions 31 to 36. You hear dietitian Catherine Weston delivering a presentation on diabulimia. You now have 90 seconds to read questions 31 to 36.
Hello, my name is Catherine Weston and I'm a dietitian with a keen interest in a little-known condition called diabulimia. The name is derived from a mixture of diabetes and bulimia, as it describes the situation where type 1 diabetics develop the behavioral characteristics of the aforementioned eating disorder. As insulin restriction is a significantly more dangerous act than calorie purging, the sooner something can be done about the countless lives being lost because of diabulimia, the better. To put things in context, it is estimated that approximately 400,000 people in the UK are living with T1. Whilst the exact number of people living with diabulimia is unknown, alarmingly up to 40% of sufferers, who are mainly female, aren't taking enough insulin to survive. With that acknowledged, it would be remiss not to mention that those affected are not exclusively women. A recent German study suggests that 11.2% of boys aged 19 and under are intentionally depriving themselves of insulin in a drive to be thin. Yet, despite the widespread reach of this condition, it is not as visible as other similar disorders, such as anorexia or bulimia nervosa. Part of the reason the condition is so low profile is the fact that the condition is not a recognized medical or psychiatric term, but rather it highlights the practice of reducing or eliminating insulin in a bid to lose weight. As diabetes sufferers cannot produce insulin but need it in order to survive, the practice of restricting their intake with the aim of losing weight is incredibly dangerous. Sufferers run incredibly high blood sugars, which has the potential to produce multiple irreversible diabetic complications. This can include neuronal, retinal and renal damage. The most common symptoms of the disease include irritability, decreased concentration and motivation, and diabetic ketoacidosis, all of which are analogous to diabetes. Rather eerily, by making the decision to cease treatment, sufferers are essentially turning the clock back on their condition. I do a lot of work with Diabetes UK in order to raise awareness of the signs and signals of diabulimia with friends and family of people with insulin-dependent diabetes mellitus. This type of outreach work was sparked by the many case studies of young people whose lives have been claimed by the disease. One such account is of the life of Amara, a 27-year-old who took her life after battling with the disease. Typically of people with the condition, Amara developed an unhealthy preoccupation with food. She also became increasingly uncomfortable taking her daily medication, comparing injecting her insulin to injecting fat into her body. Her sporadic insulin restriction then became a greater feature of her life. The unhealthy obsession with her diet led her to the discovery that despite not lowering her food intake, because she had drastically reduced her medication, she was losing weight. The weight loss is a result of the body cells failing to absorb blood sugar, with the consequence of prolonged elevated blood sugar in the individual. This causes the organs to be saturated in glucose. Amara was found dead, having taken her life after a futile years-long struggle with diabetes. Her death highlights the crisis for the medical and diabetic communities, neither of which have the resources or systems of care in place to support such a nuanced disease. In fact, such tragic consequences are so severe and such stories are so tragic that early detection is a governmental priority. NHS England's clinical team have been involved in producing the NICE guidelines on eating disorders, devoting part of the report to managing people suffering from an eating disorder and diabetes concurrently. The guidelines have been distributed nationally in a bid to tackle the illness. Furthermore, the organisation is integrating psychological services with GP practices by placing 3,000 new mental health therapists and surgeries. In addition, other private and charitable organisations are also keen to play their part. A prominent example includes Jacqueline Allen, founder of national charity Diabetics with Eating Disorders. Allen is presently campaigning for the omission of insulin for weight loss purposes to be recognised as a mental illness. The theory is that increasing the condition's visibility, it will become easier to engage multidisciplinary teams, including endocrinologists, mental health professionals and specialists like myself who specialise in the condition, to provide a 360-degree treatment service. Until that is achieved, however, the road to medical and psychological recognition continues.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a junior doctor called Graham Holder giving a presentation on the subject of hand transplants. You now have 90 seconds to read questions 37 to 42.
Good morning, my name's Graham Holder. I'm a junior doctor here at the hospital. The subject of my presentation today is hand transplants. I'm not a specialist in this area and I have no direct experience of it, but I've always found it fascinating and I'd like to share my interest in it with you. So, first of all, what is a hand transplant and why is it better than prostheses? Well, it's a type of CTA, that's a composite tissue allotransplantation, in which skin, fat, muscle and nerve bone are all transferred from one person to another. To date, it's largely been used to treat patients with both functional and aesthetic deficits that can't be dealt with by conventional methods, but this is changing. The mainstay of treatment for amputated limbs has long been prostheses, but patients often reject them because they only provide limited mobility and function, and they can be uncomfortable. In theory at least, transplanting a complete part should give much better results than even the most advanced prosthetic technology. So, more and more upper limb transplants are being performed around the world every year, and this is largely thanks to new and more powerful immune suppressive drugs. The strategies in use have been derived from the experience of transplanting organs, especially kidneys, and this has also informed the choice of drugs. Slightly higher amounts of immune suppression are used with a potent induction, followed by a low-dose maintenance regime. This regime can be supplemented by short courses of intensive therapy to overcome any episode of acute rejection. The survival rate of both patients and grafts under this regimen outperforms that for all other transplants. That's actually pretty impressive. At least one episode of rejection is recorded in 90% of cases, however, despite the immune suppressive protocol, and this is much higher than with kidney transplants. One reason for this is that hand transplantation represents a visible graft. That means you can make an immediate diagnosis of rejection based on minor changes in skin appearance, even though this has to be confirmed by a biopsy. If patients adhere to the regime, however, rejection is generally reversible. One of the challenges of hand transplantation is to achieve the delicate balance that prevents rejection whilst at the same time protecting patients from the direct toxicity of the medicaments. But this seems to be working, and infection is actually the commonest complication. So, what happens during a hand transplant operation? It's a 6-hour procedure which involves 2 separate surgical teams, one removing the hand from the donor and the other working with the recipient. Bones are joined with titanium plates and screws. As with other bone grafts, they should eventually heal together, but the plates are left in to ensure stability. Surgeons then connect key muscles and tendons before tiny blood vessels are connected using surgical microscopes. 3 major nerves are then attached, followed by large and small veins. Once blood is circulating, the recipient begins to feel the new hand. A recent case attracted a lot of interest in the UK. It was a bilateral transplant for a man who'd lost both hands in an accident at work. Now, bilateral transplants aren't so uncommon, but what made the case particularly noteworthy was the fact that he still had both his thumbs, but not the rest of his hands. So it wasn't a transplant performed at the wrist, as is usually the case, but in the substance of both hands. Nonetheless, immediately afterwards, he managed to gain some movement in his donor hands and has since improved dramatically. Indeed, just 9 months after the procedure, he was able to write a thank you letter to the surgeon. His recovery experience mirrors that of most transplant patients. The incredible thing about him is the speed at which he's gained that functionality. So, what about donors? One of the challenges of hand transplantation is that the hands not only have to fit immunologically, they also have to look right because they're going to be on view, an issue that doesn't arise with internal organs. That makes the job of finding an appropriate donor even harder. In any case, because hand transplantation is rather unusual, people have been slow to donate, and there have been occasions when surgeons had to ask for a donation when somebody's offered other organs, but not specifically the hands, and that's a really difficult thing to negotiate with next of kin at the time of death. The hand transplant program is now established and it's becoming mature. It'd be nice to think that hand transplants could become as routine as kidney transplants. Setting up a donor network is the next goal.
That is the end of Part C.